Welcome to MedMentor Prep. We truly hope you find this video useful in your learning journey. I am your host, Dr. Hassan Sudhi. Please remember the information presented in this video reflect my personal notes and insight. It is not intended for the management of your patients. Always consult a qualified healthcare professional for specific medical advice or treatment.
Systemic lupus erythematosus, SLE.
Definition: SLE is a chronic, multisystem autoimmune disease characterized by the production of autoantibodies and immune complex deposition, leading to inflammation and damage across various organs. Pathophysiology: SLE is a complex autoimmune disease characterized by multifactorial pathophysiology involving genetic, environmental, and immunological factors. 1. Genetic predisposition. Multiple susceptibility genes have been identified, including those related to immune regulation and apoptotic cell clearance. These genes are 1. HLA genes, like HLA-DR and HLA-DQ. 2. Non-HLA genes, such as complement 4, IRF5, and STAT4. 2. Immune dysregulation. The dysregulation involves several immune cells, including 1. B cells hyperactivation, which leads to the production of autoantibodies, such as anti-double-strand DNA, antibodies, and anti-Smith antibodies. 2. T cells abnormalities. 3. Dendritic cells activation. 3. Environmental triggers. Environmental factors such as ultraviolet light exposure, infections like Epstein-Barr virus, and certain medications can act as triggers in genetically predisposed individuals, precipitating disease onset or flares.
Clinical presentation.
General manifestations of SLE. 1. Fever. Fever is a common nonspecific symptom in SLE and may indicate active disease or flare-ups. It is important to differentiate these fevers from those arising from infections, which can occur due to immunosuppression associated with SLE or its treatments. 2. Fatigue. Fatigue is one of the most prevalent and debilitating symptoms reported by individuals with SLE. It is often multifactorial, stemming from inflammation, anemia, sleep disturbances, and the psychological burden of chronic illness. 3. Weight loss. Unintentional weight loss may occur in patients with SLE, often as a result of increased metabolic demands from chronic inflammation, decreased appetite, or gastrointestinal manifestations such as nausea. Skin manifestations of SLE. 1. Malar butterfly rash is a characteristic facial rash that covers the cheeks and bridge of the nose, resembling a butterfly's wings. It is often erythematous, flat, and can be triggered by sun exposure. 2. Photosensitivity. Photosensitivity refers to an abnormal reaction to sunlight, leading to skin rashes or exacerbation of existing lesions. Patients with SLE often report that sunlight triggers or worsens their skin manifestations, making sun protection essential for management. 3. Oral or nasal ulcers. These are painful, often superficial ulcers that can occur in the oral cavity and nasal passages. 4. Discoid rash. A discoid rash is typically a raised, erythematous lesion with central atrophy and scaling, often found on sun-exposed areas of the skin. While it can occur in SLE, discoid lesions may also appear independently as chronic cutaneous lupus erythematosus. Discoid rashes can lead to scarring and hair loss if untreated. 5. Alopecia. Alopecia in SLE can manifest as hair thinning or loss, particularly in patches. Musculoskeletal manifestations of SLE. 1. Non-erosive arthritis. This type of arthritis is characterized by inflammation of the joints without joint erosion or permanent damage to the bone structure, which differentiates it from other forms of inflammatory arthritis such as rheumatoid arthritis. 2. Myalgia. Muscle pain is another common symptom experienced by individuals with SLE. It can range from mild discomfort to severe pain and may involve different regions of the body. Renal manifestations of SLE. 1. Proteinuria is a significant and common renal manifestation in SLE. Levels of proteinuria can vary, with nephrotic syndrome characterized by heavy proteinuria, greater than 3.5 grams per day, being particularly concerning. Monitoring proteinuria is essential for evaluating the progression of renal involvement and guiding treatment decisions. 2. Hematuria. Blood in the urine is another key indicator of renal involvement in patients with SLE. The presence of hematuria can indicate glomerular inflammation or damage. Like proteinuria, hematuria can range from microscopic to macroscopic. It is often assessed through urinalysis, and its detection may prompt further evaluation for potential complications of lupus nephritis. 3. Lupus nephritis. It's one of the serious manifestations of the disease. It occurs in a significant proportion of SLE patients and can lead to reduced kidney function and end-stage renal disease if left untreated. Lupus nephritis is classified into different classes based on the histopathological features observed on kidney biopsy, ranging from Class 1, minimal change disease, to Class 6, advanced sclerosing lupus nephritis. Symptoms may include edema, hypertension, and worsening renal function, although some patients may be asymptomatic. Cardiopulmonary manifestations of SLE. 1. Pleuritis, or pleurisy, is common in SLE and can result in sharp, pleuritic chest pain that worsens with deep breathing or coughing. 2. Pericarditis. Pericarditis is another complication in SLE. Patients may present with chest pain, which can be sharp and is often relieved by sitting up or leaning forward. 3. Pleural/pericardial effusion. Both pleural effusion and pericardial effusion can occur in SLE due to inflammatory processes. Neurological manifestations of SLE. 1. Seizures are a significant neurological manifestation of SLE. They can result from several underlying mechanisms, including vasculitis, direct effects of autoantibodies on the nervous system, or metabolic disturbances related to the disease. 2. Psychosis can manifest in patients with SLE as altered mental status, hallucinations, or delusions. This is less common than seizures but can be severe and distressing for the patient. 3. Headache and mood disorders. Headache, particularly migraines and tension-type headaches, are frequent complaints in SLE patients. Mood disorders, including depression and anxiety, are prevalent among individuals with SLE. These disorders can be exacerbated by the challenges of living with a chronic, unpredictable illness and can lead to a diminished quality of life. Addressing mood disorders is crucial in the overall management of SLE. Hematologic manifestations of SLE. 1. Anemia is a common hematologic manifestation in SLE. It can be from anemia of chronic disease due to systemic inflammation, or autoimmune hemolytic anemia. This is characterized by premature destruction of red blood cells, RBCs, due to antibodies. 2. Leukopenia and thrombocytopenia are another common finding in SLE, often related to immune-mediated destruction or due to bone marrow suppression from the disease or the treatment. Immunological manifestations of SLE. 1. Anti-double-strand DNA antibodies are highly specific for SLE and are often associated with disease activity, particularly lupus nephritis. The presence of these antibodies can indicate a heightened risk for renal involvement and is used as a marker to monitor disease flares. 2. Anti-Smith, anti-SM antibodies, also considered highly specific for SLE. The clinical significance of anti-SM antibodies relates primarily to their association with severe disease forms, although they are not routinely used for monitoring disease activity. 3. Antinuclear antibodies, ANA, is a key initial screening tool in the diagnosis of SLE. However, while a positive ANA is common in SLE, it is not specific as it can occur in various other autoimmune diseases and even in some healthy individuals. 4. Antiphospholipid antibodies, including anticardiolipin antibodies and lupus anticoagulant, contribute to a hypercoagulable state and are linked to an increased risk of thromboembolic events, such as venous thrombosis and stroke, in patients with SLE.
Workup.
SLE workup includes the following. Blood workup. 1. Autoantibody testing including antinuclear antibodies, anti-double-strand DNA antibodies, anti-Smith SM antibodies, antiphospholipid antibodies. 2. FBC, to assess for anemia, leukopenia, and thrombocytopenia. 3. Renal function and liver function. 4. Urinalysis to detect proteinuria and hematuria. Abnormalities can indicate lupus nephritis. 5. Complement levels. Measure complement components, C3, C4, as they are often decreased in active disease due to consumption by immune complexes. 6. ESR and CRP. These inflammatory markers can provide information about disease activity but are not specific for SLE. Imaging studies. 1. Chest X-ray to assess for pleural effusions, interstitial lung disease. 2. Echocardiography evaluate for pericardial effusion or valvular involvement. 3. Renal imaging if indicated. Renal ultrasound may be used to assess kidney structure and exclude other causes of renal dysfunction. Additional assessments. 1. Nail fold capillaroscopy, to assess for capillary abnormalities which can help differentiate primary from secondary Raynaud's phenomenon. 2. Tissue biopsy if indicated. Skin biopsy for skin lesions or renal biopsy in cases of suspected lupus nephritis for definitive diagnosis and subclassification.
2019 Euler/ACR SLE classification.
To classify systemic lupus erythematosus, SLE, the Euler classification criteria are used. Key components to remember are that a positive antinuclear antibody, ANA, test is essential for diagnosis. Additionally, a total score of more than 10 points is required based on clinical and immunological criteria. When assessing each domain, it's important to use the highest score from each category. Points cannot be counted twice from the same domain. Only the highest scoring item in each domain counts. For those interested in the detailed scoring breakdown, you can refer to the accompanying table, which is available for review later. This approach ensures a streamlined focus on the most pertinent aspects while allowing for further study if desired. Let's continue with our discussion.
Monitoring and follow-up.
1. Regular clinical evaluations. Conduct comprehensive assessments at each visit to evaluate symptoms and organ function. 2. Laboratory tests. Routine blood tests. Complete blood count. Monitor for anemia, leukopenia, and thrombocytopenia. Comprehensive metabolic panel. Assess renal function, electrolytes, and liver enzymes. Urinalysis. Check for proteinuria and hematuria, which can indicate renal involvement. Anti-double-strand DNA antibodies. Levels often correlate with disease activity, especially renal involvement. Increasing levels can signal a disease flare. Complement levels. C3 and C4 are typically low during active disease. Inflammatory markers, ESR and CRP. Elevated levels may indicate active inflammation and disease activity. 3. Evaluation tools, like SLE Disease Activity Index, SLEDI.
Management.
1. General management. Multidisciplinary approach. Care should involve a multidisciplinary team including rheumatologists, dermatologists, nephrologists, and other specialists as needed to address the varied manifestations of SLE. 2. Pharmacologic treatment. Hydroxychloroquine. First-line treatment for all patients with SLE, unless contraindicated, at a target dose of 5 mg per kilogram real body weight/day but individualized based on risk for flare and retinal toxicity. Glucocorticoids, if needed, are dosed based on the type and severity of organ involvement and should be reduced to maintenance dose of less than or equal to 5 mg per day, and, when possible, withdrawn. In patients with moderate to severe disease, pulses of intravenous methylprednisolone, 125/1000 mg/day, for 1 to 3 days can be considered. Immunosuppressive agents. In patients not responding to hydroxychloroquine, alone or in combination with glucocorticoids, or patients unable to reduce glucocorticoids below doses acceptable for chronic use, addition of immunomodulating/immunosuppressive agents should be considered. Example: methotrexate, azathioprine, or mycophenolate, biological agents, such as belimumab or anifrolumab. In patients with organ-threatening or life-threatening disease, intravenous cyclophosphamide should be considered. In refractory cases, rituximab may be considered. 5. Treatment of active skin disease should include sun protection, topical agents like glucocorticoids, calcineurin inhibitors, also antimalarials, hydroxychloroquine, chloroquine, and/or systemic glucocorticoids. As needed, second-line therapy is methotrexate, mycophenolate, belimumab. I hope you found this video helpful and informative. If you enjoyed it, please don't forget to like this video and subscribe to the channel for more valuable content. Your support helps us continue to share important information. Thank you for watching.